Thanks, Dr. Sasitran. So I'll start straight away. So in the next 25 minutes, I'm going to speak about management of status epilepticus, give you the essentials, and also add some evidence and add some scenarios. So starting with the scenario, you are the first year postgraduate in ER, and parents bring a 3-year-old child with seizures. And if you're new, the senior nurse goes, "Doctor, this is status." And you wonder, oh, okay, what is that? So, and you see the child. The child is having generalized tonic-clonic seizures, has got uprolling of eyes. You know this is a seizure, and you also know this is one of the most common emergencies presenting to ER, and also one of the most common unplanned admissions or reasons for unplanned admissions to PICU. So what is status epilepticus? So this is the paper which came out from the International League Against Epilepsy back in 2015, where they redefined status depending on the duration. So they gave 2 time points. One is time point 1 at 5 minutes and time point 2 at 30 minutes. So time point 1 at 5 minutes is the time when the seizures are abnormally prolonged. And it's also the time for where they say that you have to start giving medications. And time point 2 is 30 minutes, T2, is the time when the seizures beyond which you have a high risk of long-term consequences or injury. So where did this 5 minutes come from? So we know from experience and various papers that most seizures terminate within the first 1 or 2 minutes. And most children presenting even to emergency room, 80% of them do not require anti-epileptic drugs. And 5 minutes comes from, so when the seizures is as long as 5 minutes, you're reaching the threshold where it's unlikely to self-terminate. And this T2 of 30 minutes comes from experiments done on primates back in 1970s, when they were made to have prolonged seizures, and they were shown to have neuronal injury and death. So back to our scenario, the child is still fitting. And what we need to do importantly is to make sure you time the seizures, you administer oxygen, loosen the clothing, turn the child to recovery position, put some monitoring on. If you have basic monitoring, that's okay, get some monitoring on, and don't forget your glucose. So why do we need to treat a seizure early? So we know that as a seizure prolongs, your risk of cardiopulmonary complications increase, and also your likelihood of the seizure terminating or spontaneously goes down. And from this slide, what we see is as the seizure prolongs, there's a high risk of hypoxia. That's partly due to your chest wall rigidity, secondary to muscle spasm, your poor handling of secretions. And when it goes longer, you become acidotic, even hypotensive, and very rarely even have rhabdomyolysis. So how do you treat? Remember, this is teamwork. Always call for help early, and always be one step ahead in management. So always get the medications ready and to be ready to give it at the right time. While in the first 5 minutes, while you're awaiting assessing, be ready and get a brief history to try and identify a treatable cause. So what are the common causes you have? So children presenting, most likely younger children, it's febrile seizures, then it's CNS infections, epilepsy, intracranial pathology ranging from stroke, infarcts, bleed, tumor, electrolyte imbalances, metabolic disorders, and don't forget poisons. So the clues to help us identify the etiology to find a treatable cause or your initial investigations would be your blood glucose, which is correctable easily, your calcium, your sodium. If you have a blood gas machine, which you can check along with electrolytes, brilliant, you can do that as well. Think about poisons, and medication levels are there. And also CT scan, if indicated, will help you give a clue. Next. Next, what is this? This is the time-based guideline from the American Epilepsy Society. I'm going to walk you through this, and the emphasis here is on the medications and the timing you give the medications. So the first 5 minutes is the stabilization phase, which I just spoke earlier. You stabilize the child, you time the seizure, put some oxygen on, measure the blood glucose, attempt IV access, and collect essential bloods. At 5 minutes, the seizure still continues, it's not resolved, you're going into benzodiazepines. So benzodiazepines of choice, if you have an IV access, it's lorazepam. If you don't have one, it's intramuscular midazolam. So why benzodiazepines? So the advantages is that it's very quick acting, very rapid onset, and can be given via multiple routes. You can do buccal, you can do nasal, you can do IM, IV, rectal. But please do remember, these all can cause respiratory depression, and the maximum only 2 doses, and also please give the recommended dose. So again, if you have an IV access, first choice would be lorazepam. For midazolam, the dose is slightly higher if it's an IM dose. You have to remember that. I think there was some questioning about this in the previous speaker, but again, it's a very nice landmark paper, again from NGM, where they compared intramuscular midazolam against intravenous lorazepam in a pre-hospital setting, almost 893 children and adults. And clearly what it showed was administering or giving intramuscular midazolam was much more quicker and also equally effective. So if you don't have an IV access, go for IM midas. So at 10 minutes, the seizure still continues or the child is still fitting, then you repeat the benzodiazepine dose. So now you're going after 10 minutes. Now at this stage, you have to think, if you don't have an IV access, you have to think about an intraosseous access, because from now on, your second line anti-epileptic drugs need IV or intraosseous. So at 15 minutes, there is no evidence which one is preferred. So you have 4 choices. You have fosphenytoin, you have levetiracetam, you have valproate, and you have phenobarbital. So fosphenytoin is a prodrug. The advantage of it being over phenytoin is that it can be given slightly more quickly. And the expectation is that the seizure will terminate slightly more earlier. And the side effects are also lesser. So these are 2 big articles. One is from Lancet, which showed that levetiracetam is no better than phenytoin in status. And it's also the other one from NGM, the well-known ESET trial. They compared the 3 drugs and showed fosphenytoin, valproate, levetiracetam all equally effective in status. So with this knowledge, that's why you can choose any drug, but know the complications and give them at the right dose. So at this point, I just want to mention, if you have a child with a seizure, known seizure disorder, you get a history that this child is on a drug and they have been compliant, they have a breakthrough status, then think of another anti-epileptic drug. And if the history is that they are non-compliant, consider topping it up, either half loading or full loading dose as individual. So the seizure still continues. Now you're at 40 minutes phase. So now here you're thinking about either repeating the second line drugs once more, or you're thinking about anesthetic doses. So for terminating seizures, the ideal choice would be thiopentone and propofol. But please do remember, they can cause profound hypotension. So make sure if you're going to use them, keep your fluids, inotropes ready. And I think by this time, you already have some senior help who can help you with your airway, and more personnel as well to maintain the airway of the child and help you. The safer choice, I would say, is ketamine. Ketamine at 1 to 2 milligram at induction dose is pretty safe. And recent studies have shown even in children with ICP, it's safe to use. And in children with head injury, it's safe to use. And it gives an anesthetic time of almost 20 minutes at a dose of 1 to 2 milligram per kg IV. So I just want to mention, this is the study which is happening in Italy, and the recruitment has completed. They are looking at the efficacy of IV ketamine in comparison with conventional anesthetics in treating status epilepticus. So once the results are out, my hope is that ketamine will come more ahead of some of these drugs in the algorithm. So when do you intubate children? So So you have this protocol, S guideline and algorithm. But remember, when you are at 40 minutes, yes, clearly you can go ahead, terminate the seizures with one of the drugs I mentioned, go for intubation. But if the airway is compromised at any time, the child with your first benzodiazepine dose stops breathing, you have to consider intubation. If the child is desaturating or having bradycardias, having hemodynamic instability, go for intubation early. If you're a head injury or a severe trauma post cardiac arrest stroke, think about intubation early, terminating the seizures early as part of neuroprotection, and also prior to CT scan, make sure you have a safe airway to go for CT. So after intubation, mention about just gentle ventilation. If you have blood gases, brilliant. Or while you're waiting for your transport team or you're thinking of transferring the child from ER to PICU, get the CT head if indicated. Repeat the blood gas with electrolytes, monitor your glucose, get a chest x-ray to check for your tube position, get the NG tube, urinary catheter, 3% saline or dexamethasone, if indicated, put them on a midas infusion, which will help for the seizures, also for sedation. So here at this minute, I'm just going to take a break, show you some 2 videos with reference. This is from experience. I can show you this was a child. I know this is one-way interaction here. So if people are interested, they can put it in the chat box. What do they think this child is having? So this child was already on 4 anti-epileptic drugs and was doing all these movements. And the question I had was to start a referral to PICU to start some IV midazolam. Okay. So I'll go to the next video. This is another example of a child. So what I'm trying to stress here, all movements are not seizures. And the first child had benign myoclonic epilepsy, which happens in sleep. The moment you wake up, the child is all right. And this child has got reflux. Okay, so always remember, please make sure it's a seizure. And in your practice, you also may see children with pseudo seizures. So going back now, you have a 2-year-old with seizures, sudden onset, having generalized tonic. So what will you do now? So as I said earlier, again, it's going back to basics. It's airway, breathing, circulation, high flow oxygen, measure blood glucose, confirm it's a seizure, and call for help. You get the brief history of fever for 2 days, lethargy, oxygen sats 100%, airways maintained, cardiovascularly stable, blood glucose normal, but your IV line is tissue or not working. Seizures continue. So as we discussed earlier, you go for IM midazolam. Now you're on 10 minutes post IM midazolam, seizure continues. Now you have an IV access. What will you do now? You go for, again, you can repeat the dose of lorazepam. So at 15 minutes post IM midazolam, IV lorazepam, child is still fitting, unresponsive, slightly your respiratory rate is low, your pH slightly acidotic, you have a second line, your sodium and calcium are normal. What will you do now? You remember the second line drugs. This is exactly what we will do in our unit or ER. That's what exactly I'm mentioning here. So go for fosphenytoin and levetiracetam. So at 30 minutes, you're on post-IV fosphenytoin, IV levetiracetam is going in, seizure still actively continues. You call for help and consider anesthetic agents. At 45 minutes, the child is intubated with ketamine and succinylcholine. Midazolam infusion has been started, seizure stopped after intubation. So what will you do next? Your question here will be to get an urgent CT head and transfer the child to PICU. I just wanted to mention, so this is a phase where you have children in early phase, established, refractory. So if it's the same child after coming to PICU keeps having fits, then you are entering the phase called super refractory status epilepticus. And here, the treatment becomes, people have tried lots of agents. So from thiopentone infusion, midazolam infusion, phenobarbital infusion, ketamine infusion, inhalational anesthetics like isoflurane, desflurane, pyridoxine, plasmapheresis, IVIG. Again, here the cost is very important. Depending on the cost, then your treatment should be shared. So again, now coming back, when do you wake them up? You have a child who's been a known seizure disorder, who's had a big fit, you have intubated them, now seizures terminated. If there's no intracranial pathology and it's just a breakthrough seizure, you can wake them up after the seizure terminates. And the rest of them, it all depends on the etiology and what you're treating. EEG here is very useful to identify non-convulsive status. Some of the children after intubation, if you give them long-acting muscle relaxant, you may not know what's happening. So please remember EEG in that case. If you have facility for EEG, we use it, we have the facility of continuous EEG in our PICU, and we also use it for burst suppression. Also, it helps identifying non-epileptic seizures. I just want to mention briefly on home care. Please remember basic life support is a must for every caretaker for the child with seizure disorders. If you're prescribing nasal midazolam, please make sure they have basic life support, understand what they're doing with the written instructions, and also a video recording of seizures. So in summary, time them, look for treatable causes, call for help early. Your ABCs, glucose, benzodiazepines, second line will be phosphonatoin, Levipil, valproate, phenobarbital, third line ketamine, anesthetic agents, and give them at the right time with appropriate management. Thank you. And I would like to acknowledge Dr. Radhika, who's a senior consultant in ER, for her input, and also Dr. Tangavir for his input as well. Thank you.
Thank you, sir. Thank you for a comprehensive overview of status epilepticus management. And it was very much focused towards emergency practitioners' perspective. Thanks for that. Special thanks for that. And we will go directly to the questions. There are a few interesting questions. So the first question is, how to differentiate from tetanus? How to differentiate status epilepticus from tetanus cephalic? This is one question in the chat box.
Okay. That's difficult. I think your benzodiazepine works in both. It's been a while